and thank you for joining our Sudan surgical club meeting. Today we're going to talk about colorectal cancer in general, and hopefully in future session we're going to give you the recent guidelines in colorectal cancer. But first, let me thank Muhammad and his colleague for creating this excellent platform for our training, surgical training, in which they can share skills and knowledge with other people in Sudan and abroad. I think it is a great platform, and I hope everybody will benefit a lot from it. Yesterday we had a meeting with the Sudanese Medical Specialization Board, and the meeting endorsed this platform as an excellent platform for training for our staff, and everybody agreed that they should participate positively with lectures and knowledge to enrich this platform. Welcome everybody, and hopefully I will give you a lecture that you can benefit from. Okay, we'll start. Ready يا محمد؟
يس يا مستر، بس ممكن ترفع الصوت شوية.
اوكي كده واضح؟
كده كويس يا مستر.
اوكي طيب. Colorectal cancer is one of the most common cancer all over the world. Reported that there were 1.2 million new cases and 0.6 million cancer deaths worldwide. The 5-year survival rate for early stage colorectal cancer is greater than 90, whereas the 5-year survival rate for those diagnosed with widespread cancer is less than 10%. Early diagnosis is therefore of utmost importance. In Sudan, colorectal cancer is the third commonest cancer in both men and women. Worldwide, in Europe, it is the second most common cancer, and globally, it is the third commonest cancer. The incidence is 40 to 45 per 100,000 population. The colon cancer is equal for men and women. The rectal cancer incidence is 32 per 100,000 population. A woman is 22 per 100,000. Yani, we're talking for rectal cancer, for colon cancer is 1 to 1, the rectal cancer 1.5 to 1. From those, most of the cases, they present electively in 80%, and they present as an emergency case in 20%. إذا شفنا regional data في Middle East and Africa, most of the cases are in people less than 40, which is very unusual when compared to other parts of the world. We find that in colorectal cancer is more people above 60, like in Africa and the Middle East, we see this curve, the blue light, people less than 40 years old, they represent about 30% of the population. And if we include the people under 50, we'll find that about 50% of the population in Africa and the Middle East. So colorectal cancer in Africa and Middle East present in early age group. If we look at the world, you see the light blue in Africa and the Middle East is quite significant compared to the rest of the world. Prevention, asymptomatic population, lifestyle habits to reduce the risk of colorectal cancer, regular physical activity is recommended, and also to reduce the risk of colorectal cancer, weight reduction is recommended for overweight person, and to refrain from smoking. At diet specification, the general diet recommendation, it should be recommended fiber-rich diet of 30 grams per day. Alcohol consumption should be restricted, and red or processed meat should only be consumed in a small amount, not daily. Colorectal screening for asymptomatic population. Here we have to emphasize that we have two populations. One is the symptomatic population, and the other one is the asymptomatic population. When we talk about screening, we talk about the asymptomatic population. That means if a person presents with any symptoms suggested of bowel problem or rectal problem, he should have colonoscopy or other screening methods. But when we're talking about screening for asymptomatic population, that means the screening for people who don't have any symptoms. An age colorectal cancer screening should begin at the age of 50 for asymptomatic person. Due to the increased life expectancy, no upper age limit for screening can be given for colorectal cancer. That means we start the screening from 50, and as long as the patient is fit, he can continue in the screening program. The method of colorectal cancer screening, there is two types of method must be differentiated for the screen of colorectal cancer. One of them is to detect mainly cancer. This one is including the fecal occult blood test, genetic stool testing, and M2BK. And the other test, the other arm of the testing is detect adenomas and cancer, which is the colonoscopy, sigmoidoscopy, CT colonoscopy, capsule endoscopy. I'm going to talk about all of them and see which one is now currently recommended for screening. As I said, there is a colonoscopy, sigmoidoscopy, fecal occult blood testing, genetic and other stool testing, CT colonoscopy, and capsular endoscopy. Endoscopic methods, colonoscopy has the highest sensitivity. Now, colonoscopy is the gold standard for screening for colorectal cancer. Has the highest sensitivity and specificity for all methods for the early detection of colorectal neoplasia. Therefore, it is considered as a gold standard. Only endoscopic methods are diagnostic as well as therapeutic method, and have the advantage that they can detect non-bleeding cancer and adenoma with high sensitivity. The complete quality assured colonoscopy has the highest sensitivity and specificity for detection of cancer and adenoma, and therefore should be used as a standard colorectal cancer screening. After a negative examination, colonoscopy should be repeated every 10 years. Colonoscopy should be performed according to the German guidelines. They are one of the guidelines, including a digital rectal examination. For those taking part in colonoscopy screening according to the guidelines, additional fecal occult blood testing screening is not necessary. Right. There is population, as I said, colonoscopy is the gold standard screening method. Colonoscopy can detect a large number of cancer at an early stage as well as adenoma in the whole colon. Sigmoidoscopy is only used in screening if the patient refuses to have a full colonoscopy. Those people, we can offer sigmoidoscopy to detect, to see the left side of the colon, plus fecal occult blood testing. And if the fecal occult blood testing is positive, you have to tell them that they need a full colonoscopy. So sigmoidoscopy and fecal occult blood testing is only offered for people who refuse to have colonoscopy. Stool testing for persons with average risk colorectal cancer who do not want to have a colonoscopy, as I say, fecal occult blood should be conducted annually. In this population, you should offer them a fecal occult blood annually, and if the fecal occult blood is positive, then you have to tell them that they need a colonoscopy. In our situation, fecal occult blood testing is not useful because we have here in developing country, we have infectious diseases like amoebiasis, schistosomiasis, and other infectious diseases, and usually the sensitivity and specificity for fecal occult blood testing is not that good. So we rely mainly on colonoscopy. Again, stool testing for fecal occult blood should only be offered internationally for people who refuse to have colonoscopy. Genetic screening test, stool testing for DNA changes, which is one of the new tests, which we call the M2BK stool test, which detects the DNA changes in stool and detect people who have early cancer. Should not be used for colon cancer screening in asymptomatic population. That means if a patient is asymptomatic, stool testing for M2BK is not routinely done. Neither CT colonoscopy nor MR colonoscopy. Screening test, the rest of screening tests I mentioned before is CT colonoscopy and the stool testing. A CT colonoscopy and barium enema, we should only offer them if you do a colonoscopy and you fail to see the rest of the colon. And it mean that means if you don't complete the colonoscopy, then you have to see the rest of the colon by doing CT colonography. And this is the only use of CT colonography in screening. So, in conclusion, the gold standard for screening is the colonoscopy. The other tests, sigmoidoscopy and fecal occult blood, you only do them if the patient refuses to have a colonoscopy. Here, this is the table show you the guidelines for doing colonoscopy and other tests. Let's go over a few things here. In a low-risk patient, asymptomatic, no risk factor, you offer fecal occult blood testing and flexible sigmoidoscopy or colonoscopy in people above 50 years old. For low-risk group, total colon examination, colonoscopy, we start at 50 years old, and then if it is normal, you do it every 5 to 10 years. For moderate risk group, and the moderate risk group is defined as, usually they are 20 to 30% of the population and moderate risk group. Colorectal cancer in a first degree relative, age 55 or younger, or 2 or more first degree relatives of any age. For moderate risk group D, you offer a colonoscopy at 40 years or 10 years before the younger case. Yani if they have a patient who developed a colorectal cancer at 50, then you offer his family group colonoscopy at the age of 40. And if that is normal, then you do that every 5 years. في المودريت ريسك جروب برضه في colorectal cancer in the first degree relative over the age of 55. That one is below the age of 55, you start at 40. Above the first degree relative, above the age of 55, you do the colonoscopy at the age of 50, then every 5 to 10 years. I will leave this this table for you to review. It's very important. You go through it, and because for the screening population, all people confused when to do the colonoscopy and when to repeat it. We'll go for the high risk groups, 6 to 8% of the people. But the high risk group, this is people with a family history of hereditary adenomatous polyposis, family history of hereditary non-polyposis colorectal cancer, اللي هو Lynch syndrome. ففي الFAP, familial adenomatous polyposis, usually you start the colonoscopy at the age of puberty, 12 to 14 years, then you do it yearly or 2 yearly till the age of 20, and then after that you do it every year. في family history of hereditary non-polyposis colorectal cancer, you start at the age of 20 to 40. You mean 20 to 40, you do it every 2 years, and then after the age of 40, you do it every year. In people with inflammatory bowel disease, usually إذا كان عندهم ulcerative colitis, you do colonoscopy and you do it every 1 to 2 years from the age of 15 years if they have left side colitis. If they have a pancolitis, they have colonoscopy starting from the age of 8. You can go through this and revise it later when we record the video. Right. Carcinoembryonic antigen. What is the role of carcinoembryonic antigen in colorectal cancer? Carcinoembryonic antigen is a glycoprotein, not specific to colorectal cancer. It is also seen in cancer of stomach, lung, and breast. Can be elevated in non-malignant conditions, alcohol liver cirrhosis, inflammatory bowel disease, pancreatitis, COPD. If present with colorectal cancer, will only indicate that the tumor cell have penetrated the bowel wall, at least Duke's B2. What is it useful for? CEA, what is it useful for? It is useful for preoperative CEA level more than 5 is associated with poor prognosis. Post-operative CEA can serve as a measure of completeness of tumor resection. If the preoperative CEA is elevated and does not fall within 1 month of the operation, you always think that probably this patient has a micrometastasis. You have to monitor it for tumor recurrence every 3 months for the first 1 year, because if it is raised, that means you have a local recurrence or metastasis. Monitoring of response of treatment of metastatic disease also is very useful. When you give treatment for metastatic disease and the CEA level is going down, that means the patient is responding. If it is not, that means the patient is not responding. CEA level decrease in most patients who have responded to chemoradiotherapy. What is the natural history? Majority of colon cancer arise from colonic adenomatous polyps, what we call the polyps cancer sequence. Polyps, usually a colorectal cancer, natural history suggested that the cancer of the colon and rectum usually arise in a polyp, and this progressed to a carcinoma. This progression from normal colonic epithelium to this plastic epithelium, initial adenoma, intermediate adenoma, then to go to large adenoma, then carcinoma and metastasis. This sequence is regularized by multiple genes, and to develop an adenoma and then carcinoma, you have to have mutation in genes. Usually there is activation gene of suppression genes. When you stop the suppressor gene, the cells replicate and develop adenoma. Here we have the mutation in, say, when you start, we have the mutation in ABC gene, adenomatous polyposis coli gene, then mutation in KRAS gene, mutation in DCC, mutation in B53, and other genes, and that lead to progression from adenoma to carcinoma. In general, usually these genes are either suppressor gene or activation gene. When you stop the suppressor gene or you promote the activation gene, the tumor progresses from adenoma to carcinoma. We're going to talk about this later. الكولونيك adenoma, الكلاسيفيكيشن بتاع الكولونيك adenomas is usually divided into different types. عندنا neoplastic adenomas, عندنا hamartomatous, inflammatory polyps. Polyps يعني polyps as general, they are neoplastic, hamartomatous, inflammatory, unclassified, and miscellaneous polyps. For neoplastic polyps, the most important are the polyps, there is different type of neoplastic polyps, and the histology either it is tubular, tubulovillous, or villous adenomas, neoplastic. Tubular adenoma is the benign adenomas. What risk of malignancy is small. When you go to tubulovillous, the risk of malignancy is intermediate. The villous adenoma, the risk of malignancy is high. Tubular adenoma are more common and they are small, pedunculated. The villous adenoma are large, sessile, and more ominous. They are usually found in the rectosigmoid in elderly patient. في الهيريديتري adenomas, the familial adenomatous polyposis, a mutation occur in the ABC gene. There is hundreds to thousands of polyps, usually in all the colon and the rectum by the second decade of life. Colon cancer developed by the age of 40 and usually they need a pan-proctocolectomy. The other type of cancer is the hereditary non-polyposis colorectal cancer, and these we call them the Lynch syndrome. So the polyps, we divide them as neoplastic, hamartomatous polyps, the juvenile polyps, and the Peutz-Jeghers syndrome polyps. الانفلاماتوري طبعا بيكونوا في الulcerative colitis، في الشيستوزومايسيس، unclassified polyps زي hyperplastic polyps. And then they have miscellaneous زي lipomas, leiomyoma, carcinoid polyps. As we say that all polyps, usually the cancer sequence is polyps to cancer. The polyps develop progress to cancer, and that usually take about 15 years. When the mutation is activated and more aggressive, like the hereditary polyposis syndrome, and progression that occur in a rapid sequence, so usually might take only 3 to 5 years to progress to cancer. So all polyps need to be excised to prevent the progression from polyp to cancer, adenoma to cancer. I mean the adenoma. All adenomas, they have to be excised to prevent this progression from adenoma to cancer. An easiest way to do it is by snaring. If they have an adenoma, you just go and snare it endoscopically. Sometimes this adenoma have a broad base, and that need to consider, then you cannot snare it, then you have to consider endoscopic resection. في other option اللي هي endorectal microsurgery or endoscopic resection by endoscope or by microsurgery. Sometimes the adenoma is very large. If all these options fail, then you have to resort for surgical resection. Right. Recently, we have changes in the incidence of colon and rectal cancer. There is a gradual shift towards right-sided or proximal colon cancer that has been observed both in the United States and internationally. The greater increase in incidence is in cecal primaries, and this change in anatomical distribution of colorectal cancer may be in part related to the improvement in diagnosis and treatment, because people now are doing more colonoscopy and screening and removing polyps. This might be one of the reasons that the left side tumor decreasing in number, and there is increased screening by flexible endoscopy with removal of adenomatous polyposis in descending colon. But there also appear to be a true increase in the incidence of ascending colon and cecal tumor. This is most probably, this is an international data. Is this situation applicable to us in Sudan? I don't think so, because we still, this is the local data we had at our institute at Soba University Hospital, and most of the data from other hospital and regional data show that most of our cancer are in the rectum and left side. We have, this is our last incident report, show that the rectal cancer is about 60%, the left colon cancer is 10.4, transverse is 4, the right side tumor is 25%. So still in our region, we see more of the rectal and left side tumors. Clinical presentation, usually people with colon and rectal cancer presented with abdominal pain, changes in bowel habit, hematochezia or melena, weakness in 20%, anemia without other gastrointestinal symptoms, and weight loss. This is a general symptom, but when we take the symptom according to site, for the left side tumor, because the bowel caliber is small and the pieces at that side are usually more well formed, usually people present with altered bowel habit, bleeding, tenesmus, abdominal distension, constipation, not like the right side tumor, because the right side, the colon is big and the feces are more fluidy. So people usually with right side tumor presented with either anemia of unknown origin, or the tumor grows for long time and they present with a mass. In the rectum, usually people present with, again, altered bowel habits, tenesmus, bleeding, which can be mixed or at the end of the stool, sense of incomplete defecation. This is symptom specific for the rectal cancer. As I said before, 20% of cases present as emergency with either obstruction or perforation. This is just a picture of a barium enema showing a core, upper core appearance in the sigmoid colon. This slide just shows that when you have a combination of symptoms, especially in the rectum, rectal bleeding, mucus discharge, change of bowel habit, there is 80 to 90% chance that you have a rectal tumor if you have the combination of these symptoms. Abdominal pain can be caused, when a patient presented with abdominal pain, it can be caused by partial obstruction or peritoneal dissemination or intestinal perforation leading to generalized or localized peritonitis. When they present with tenesmus, usually it's caused by rectal cancer, may be involving the pelvic floor muscles. A locally advanced lesion may involve the sciatic or obturator nerve, and that can lead to people presented with neuropathic pain syndrome. Hematochezia is more often caused by rectal rather than colon cancer. A change of bowel habit and obstruction symptoms are more common presenting symptoms for left side tumors. Metastatic disease occur in approximately 20% of patients, and they will have distant metastases at the time of presentation. And the colorectal metastasis usually goes to the brain in 8%, the bone 4.6%, the lung is 16%, and most of the metastases go to liver 40 to 50%. And you also have peritoneal metastasis in 10 to 15% of people. What is the impact of symptom on prognosis? Patients who are symptomatic at the diagnosis have a somewhat worse prognosis. When the patient presents with symptoms at the diagnosis, usually they have more worse prognosis than the patient who present with asymptomatic. In one report, the 5-year survival rate for symptomatic and asymptomatic patient was 49% versus 71% in the symptomatic patient. Obstruction and perforation, although uncommon, they carry a poor prognosis independent of the stage. The tumor which present with hemorrhage have been thought to have a better prognosis because of their tendency to be diagnosed earlier. What is the impact of tumor location on the prognosis of colorectal cancer? Right side colonic tumor are diagnosed at more advanced stage within stage 4 disease and showed a significantly worse prognosis, the right side. Stage 4 right side colon cancer is oncologically more aggressive, and the other thing which also show that the impact of the tumor location and the prognosis, an older age, female sex, large tumor size, the things which also show that worse prognosis is older age, female sex, large tumor size, poor differentiation, mucinous adenocarcinoma, and singly trained cell carcinoma. They all carry a worse prognosis. Emergency colon cancer occurs in 20% of the population, and usually the emergency presentation, either they present with bowel obstruction, they can present with perforation, which can be localized in form of abscess formation, or free peritonitis. They can also present with profuse bleeding. They can present with severe anemia, with secondary symptoms like MI, cardiac failure, atrial fibrillation, and dyspnea related to the severe anemia. I'm going to talk about synchronous. What is synchronous colorectal cancer? Synchronous tumor defined as 2 or more distinct primary tumors separated by normal bowel and not due to direct extension or metastasis. It is occurring about 3 to 5% of the patients. And we have the metachronous cancer, which is defined as a non-anastomotic new tumor developing at least 6 months after the initial diagnosis, when they usually occur in 1.5 to 3% of patients in the first 5 years post-operatively, and that can rise to up to 9% after several decades if they survive the primary cancer. So, how you diagnose colorectal cancer? As we said before, in symptomatic patients, usually we do a full colonoscopy. If the patient is symptomatic and he is above 50, that means the age for colonoscopy, he should have a full colonoscopy, whether he presents with left side symptoms or right side symptoms. He should have a full colonoscopy, full stop. As I say, screening, yes, we start for the age of 50. If the patient have first degree relatives, then you start 10 years before the first degree relative have developed the cancer. Colonoscopy is the single best diagnostic test, and it can localize the lesion. You can take a biopsy, you can detect synchronous new blood, and you can remove polyps. If the patient is symptomatic and presented before the age of 50, and his symptoms are in the rectum or left side, you can start by doing a sigmoidoscopy, and if that is abnormal or you detect any abnormality in the sigmoidoscopy, then you can go for a full colonoscopy. This is a second option. So the use of sigmoidoscopy is limited to people who presented with the age less than 50 and symptoms in the rectum or left side. And even if you do that and you find any abnormality, then you go for a full colonoscopy. What is the role of CT colonoscopy? The CT colonography, as I said before, it is not useful for a routine screening in asymptomatic patients. We only use CT colonoscopy if, number one, the patient refused to have a full colonoscopy, because sometimes people refuse to have colonoscopy because of the risk of colonoscopy, although they are very rare. But sometimes people refuse to have full colonoscopy and they symptomatic, then you can go for CT colonography. The technique is the colon is distended with carbon dioxide instead of room air, and we give prescopan. The patient is supine and drone view, and then visualize the colon. It is very excellent modality. It's accurate. It is can detect polyps more than 1 centimeter in diameter, and cancer. Sensitivity is 88 and the specificity is 95. Is well tolerated and safe. But as I say, you only use that if the patient refuses to have colonoscopy, or you do a colonoscopy and you fail to complete the colonoscope due to whatever difficulty. You couldn't see the tumor obstructing, you cannot see the rest of the colon, or technical difficulty, you couldn't see the rest of the colon, then you can complete that by doing a CT colonography. It rules out proximal lesion. Well, it may explain why the colonoscope is difficult. Sometimes it is difficult and you do a CT colonography. Sometimes you can see that why you have a difficult colonoscopy and you visualize the rest of the colon. And as this picture showed that sometimes the lesion is extracolonic, and that might be the cause of the failure of the colonoscope. MR in rectal cancer. The role of MR is mainly in rectal cancer, not in colonic cancer. The MRI is a good modality in studying it assesses the tumor height, circumferential resection margins, extramural venous invasion, the depth of the spread, the nodal status, and in low rectal cancer, the surgical resection plans. And if you give the patient neo-adjuvant treatment and post-treatment MRI assessment, is very good to again assess all these parameters. The MRI for the rectum is better than the CT. Saying that in Sudan or other places, if you want to do an MRI, you have to have an MRI protocol. That means an MRI or radiologist who can do an MRI of the rectum, which have a specific protocol to see all these parameters. If you don't have the protocol or the coil of the rectum to do a proper MRI, then CT is better. For our registrar, I think in Sudan, our MRI, most of the places, they don't have the rectal coil. So in our MRIs, we don't have a good experience with MRI because we don't have a good quality pictures. So usually I tell my registrar here to do a CT with contrast is better than MRI. But ideally, if you have a good setting, MRI for the rectum is the ideal. Okay, measurement of rectal cancer height. Usually location, there is really a controversy in the measurement. What is rectum? Some people say rectum is 12 centimeter. Other people say the rectum is 15 centimeter. I tend to believe that the rectum is 15 centimeter, and most of the data show that the rectum is 15 centimeter. But all that depends on how you measure the rectum. Most of the people who use the flexible endoscopy, because of the colon of the endoscope, they usually tell you tumor as 12 centimeter. And if you measure that by the rigid sigmoidoscope, you will find that the tumor is at 10 centimeters. So measuring the distance of the tumor is best done by the rigid sigmoidoscope. and we talk about low rectal tumor is up to 5 centimeter from the anal reference level هو الانال verge. Mid rectal tumor from 5 to 10, and then we have the high rectal tumor from 10 to 15. And as I said, these measurements are done by the rigid sigmoidoscope, and you have to take into account when you do a flexible sigmoidoscopy. And most of the time, I think it is the surgeon who do the endoscopy should tell if the tumor is in the rectum or the sigmoid. It is, if you see the tumor in the rectum, then it is a rectal tumor, especially the tumor which lies in the high rectum. But anyway, we define low tumor up to 5. 5 to 10 is mid-rectal tumor, and then 10 to 15 is the high rectal tumors. This is an MRI done with the rectal coil, which shows that the tumor invading the prostate. The MRI, as I said before, if it's done correctly, will show most of the information we need to do the preoperative assessment. Endoscopic ultrasound in rectal cancer, usually this modality is used to assess early disease like T1 and T2 before we do a sphincter preserving procedure or TEMS for early disease. The endorectal ultrasound is very good to tell you where is the tumor. It involves only the mucosa or submucosa, and it is a good modality if you're going to have local excision of early tumor. But we don't use it as routine for other type of tumors. Staging of colorectal cancer. This slide shows the modified Dukes classification. In Dukes A, as you see, it is only involved the mucosa, submucosa. Dukes B, B1 showed that it is involving the mucosa, submucosa, muscularis. B2 involving the extending the whole, involving the serosa. C1 and C2 involving the lymph nodes, and D when they have a distant metastasis. Primary tumor, as I say, now we do the TNM classification. It is the international classification used now, and most of people comparing their data using the TNM classification. TX tumor extent not determined. T0 no sign of invasive cancer. T1 tumor invade the submucosa. T2 tumor invade muscularis propria. T3 tumor invade through muscularis layer into mesenteric fat tissue. We divided into T3A, B, C, and D. And then we have the T4 tumor overgrowth on other organ structure or invading the visceral. Bordeaux T4 is divided into T4A and T4B. You can look it up in the text, but I think it is important to memorize all this to do a proper staging of patient before operation. A regional lymph node, also with TNM classification. NX nodal status is unknown. N0 no regional lymph node metastasis. N1 metastasis in 1 to 3 pericolic or perirectal lymph nodes. N2 metastasis in 4 or more lymph nodes. At distant metastasis, MX not investigated, and then M0 no distant metastasis. M1 there is a distant metastasis. All of you know the Dukes classification. This is the original Dukes, A, B, C, and D. And then we have, as I told you before, we have the modified Dukes. You can review it in the slide before. Okay. Now, usually when we have a patient with colorectal cancer or any other cancer, the best option of treatment is to have an MDT, multidisciplinary meetings to decide about this patient treatment option. And usually MDT in colorectal involving the surgeon, oncologist, pathologist, contact nurses, radiologists, and sometimes on demand you have a liver surgeon, urologist, gynecologist, thoracic surgeon, vascular surgeon if you need it. The MDT is very important because it is improve the communication, and there is less risk of personal mistake. If you take the decision alone, there is always a risk of personal mistakes, more tailored treatment, especially for rectal cancer, and more patients included in studies, and it is educational for the staff, for all the staff, the young staff and the senior staff. So MDT is very important for decision making in colorectal cancer. Preoperative MDT. البري-operative MDT في الكلينيكال برزنتيشن usually you will take a patient history, a physical and endoscopy finding, pre-operative problem, incontinence, urinary function of the patient, a sexual function of the patient. We have to know about all of this because there will be, you have to assess all this because you want to know the post-operative complication which affect these organs. A diagnostic workup for radiology, nuclear medicine, and pathology, complementary examination, you have to examine the heart, the lung function, and you have to discuss with the patient his view and wishes. Then you have to discuss with him the suggestion and decision of the best treatment. It is always very important to include your patient after you make a decision in multidisciplinary meeting. You have to discuss all this with your patient to come with the best treatment option for your patient. I always tell my registrar it is not just tumor at 5 centimeter APR above anterior section. It's not like this. You have to consider so many things before you make a decision that your patient is going for anterior resection or for an APR. Patient age, patient wishes, sphincter function of the patient. It's not good to do an anterior resection in a very old man with very poor sphincters. He will end with fecal leakage and soiling all his life, and that is not a good quality of life. So before you make a decision, it's not only about where is the tumor. It is so many things you have to consider before you make a decision whether you're going to do an anterior section or APR. The post-operative MDT, just let me move this. Okay, a post-operative MDT. After you do the operation, what you have to have another MDT to discuss. You compare a pre-operative clinical and radiological finding with the post-operative pathology. Do we have a clear margin or not? What is the tumor stage? What is the number of lymph nodes examined? And ideally, you should have more than 12 nodes to say that the resection is adequate. Stage 3 lymph node metastasis, stage 2 with risk factor. Then you have to consider adjuvant chemotherapy if not contraindicated. There's so many things you have to discuss in the post-operative MDT meeting. You have to see what is the stage of the tumor, the lymph node involvement, the involvement of the margins, what is the stage of the tumor, because all that will help in making a decision about the post-operative treatment of your patient. Okay. Surgical management of primary colon cancer, surgery is the only curative modality for localized colon cancer. This is very important. Surgery also provides a potentially curative option for selected patients with limited metastasis disease in liver or lung. Again, if a patient has a colon tumor and he has metastasis, that doesn't mean that you don't go and do surgery, because if you have a cancer, even with metastasis, you have to do, and the primary tumor is resectable, you have to go for surgery, because it is, even for palliation, if you remove the tumor, then you avoid complication like obstruction or perforation or bleeding. Preoperative evaluation, there is a complete history and physical examination, complete blood count, serum electrolyte, liver enzyme, carcinoembryonic antigen, urine analysis, coagulation profile, CT scan of the abdomen and pelvis and chest. It is very important for staging. Ideally, colonoscopic examination of the entire colon prior to surgery. Bowel preparation. There is a lot of controversy about bowel preparation in colorectal cancer. Preoperative mechanical bowel preparation reduces both the fecal content and bacterial content in the bowel lumen. The use of mechanical bowel preparation with prophylactic antibiotics has been reported to decrease the incidence of wound infection, and intra-abdominal abscess after colorectal surgery. Some have questioned the need for routine mechanical bowel obstruction, mechanical bowel preparation, prior to elective colon cancer surgery. There is now reports and papers showing that doing surgery without bowel preparation is as safe as doing it with bowel preparation. I think still this is a very debatable subject, and people will continue to debate this subject. In our practice here, we do believe in bowel preparation, and we're still doing bowel preparation in our patients. There is, as I told you, there is multiple randomized clinical trials showing that it's safe sometimes to do surgery without the bowel preparation. There is general surgical principle. The goal of colon cancer surgery is to completely remove the tumor along with the major vascular pedicle. Now people are talking about central vascular ligation, and to completely remove the tumor and the central nodes in any type of colon cancer, along with the major vessel pedicle feeding the affected colonic segment and the lymphatic drainage from that segment. In block resection of invaded structure indicated if there is attachment or adhesion of the tumor to any organ or structure. The resection margin, the proximal and distal resection margin should be at least 5 centimeters for the tumor. Although in rectal cancer, especially in low rectal cancer, 2 centimeters is considered enough, and nowadays even 1 centimeter in very low cancer is considered enough. Regional lymphadenectomy provide important prognostic information that guide adjuvant treatment and is of therapeutic value as well. It's very important to, as I said before, to get at least 12 nodes and to examine them, and that will decide about your adjuvant modality. Emergency surgery, 20% of colon cancer in UK and all over the world can present as an emergency, 16% as an obstruction, and in this 16%, 70% of obstructive cancer are in the left side. Mortality, when they present as an emergency, the mortality is 15 to 40% after an emergency surgery, and it is less than 5% after elective surgery. Patient with obstruction, The first specific investigation is a plain abdominal X-ray. And sometimes I find people go for doing a patient with typical obstructive symptom. People jump to do an ultrasound and other investigation. I think a plain X-ray is your first choice for diagnosis of sign obstruction. Before committing the patient to laparotomy, it is important to identify the site of the obstruction and to exclude pseudo-obstruction. That's why if you have the facility, abdominal CT with contrast has increasingly replaced the water-soluble contrast enemies. Optimal management for obstructing cancer depends upon the condition of the patient, what tumor location. It is not a straightforward decision. If you have a patient with obstruction, you have to consider so many things before deciding what type of surgery you're going to do. If you have a right side tumor, emergency right hemicolectomy is the best option. If you have a left colon cancer, surgical options are so many. Depends on the patient condition, and the status of the bowel. You have resection of the tumor with primary anastomosis, with or without temporal proximal diversion. I will go for resection of the primary tumor anastomosis with defunctioning, or as I said before, this depends on the status of the bowel. Then you have the other option is resection if the bowel is dilated and it is not visible to do primary anastomosis and colostomy. You have to go for a Hartmann procedure. You resect the tumor and then you do a colostomy. Sometimes the tumor is adherent and you can't do anything at the time of emergency surgery. Then you go for proximal diversion with colostomy, and then you optimize the condition of the patient. Then you go for elective resection at the second operation. Emergency surgery should be carried out during daytime. So emergency surgery, as I tell you before, is usually a very risky procedure, and it should be done, if possible, during daytime hours by experienced surgeon and anesthetist to decrease the morbidity and mortality from the operation. Colonic stenting for bowel obstruction. Sometimes, if a patient presented with bowel obstruction, there is an option of considering the use of colonic stent in patients who present with acute large bowel obstruction. You have to do a CT of the chest, abdomen, and pelvis to confirm the diagnosis of mechanical obstruction and determine whether the patient has metastatic disease or colonic perforation. Then you put a stent. A stent will act as a bridge to optimize the patient mineral obstruction, relieve the obstruction, and optimize the patient condition till you go and do more sort of elective procedure later on. So if you have the facilities and the patient present with obstruction, if you have the facilities, then you can use an stent to optimize the patient condition before doing surgery. So stenting and clinical success rate in experienced hands is 80%, and mortality and hospital stay is unaffected. Stoma rate is significantly reduced, while cancer-specific survival is not worse than without stenting, and it is a reasonable alternative to emergency surgery. A patient with perforation. If a patient who had a chronic or tumor present with perforation, the management of perforated tumor has to be individualized. As I told you before, it is not 1 + 1 = 2. You have always to think about the patient, the comorbidity, the patient age, the time of presentation, the status of the patient before you decide what type of management you can do for this patient. A treatment alternative depends on the patient overall condition, whether peritonitis is localized or generalized. If the patient is stable and the peritonitis is not generalized, tumor resection with primary anastomosis and defunctioning colostomy can be performed. Primary anastomosis is not recommended if there is a diffuse peritonitis or free perforation and the patient medical condition is unstable. In that case, either you clean and do a colostomy, or you resect the area and do a colostomy. For unstable patient, percutaneous drainage or a proximal diverting colostomy can be performed. And if the patient had a perforation and his condition is not stable, all what you need to do is just wash and put a drain and put a colostomy. So treatment of perforation depends on the patient condition and again on your setting and experience when dealing with such patients. Laparoscopic colectomy. Nowadays, most institutes go for laparoscopic surgery for colorectal cancer. First attempted in 1990 and slowly gaining acceptance. There is a steep learning curve as the cost, the time, the oncological concern, the risk of post-site recurrence. All these fears are now overcome, and laparoscopy for colon and rectal cancer now become a valid option for all patients. Advantage of laparoscopy is less blood loss, fast recovery, earlier return of gut function, low morbidity, and magnification view allow precise dissection of tumors. It reduces the pain, improves the osmosis, decreases the adhesion, decreases wound infection rate, decrease negative immune effect for surgery. Usually patient after laparoscopy, although the operation time is long, the recovery rate is quicker and the patient feels better sooner than the open surgery. The safety and advantage of laparoscopic colectomy for cancer have been much debated, لكن most of the randomized controlled trials in North America, UK, or Europe show that laparoscopic surgery is superior to open surgery. Management of cancer in a polyp. Endoscopic resection alone is a reasonable approach for favorable risk early stage colon cancer arising in a polyp. طبعا في classification for البوليبس اسمه hadit classification للstages of الكانسر في البوليبس. You can look it up. لكن high risk factor of residual cancer and or nodal metastasis if the cancer developed in a polyp, إذا كان في poorly differentiated histology, lymphovascular invasion, cancer at the resection or stalk margin, invasion into muscularized propria of the bowel wall, T2 lesion, invasive carcinoma arising in a sessile or flat polyp, invasive carcinoma with incomplete polypectomy. دي كلها high risk factor for انه ممكن يحصل recurrence, and in these cases you have to resort for surgical resection rather than endoscopic resection of polyps. Adjuvant therapy for colon cancer. The colon cancer is straightforward. If you have stage 3, then you go for adjuvant chemotherapy. In stage 2, if it is favorite stage 2, then you can observe the patient. Stage 1, طبعا you don't need to give any adjuvant chemotherapy. For stage 3, you give chemotherapy. Stage 2, if it is favorable condition, then you don't need to give chemotherapy. If it is unfavorable, that means بنقول بالتالي stage 2 unfavorable إذا كان الديفرنشيشن is poorly differentiated or في lymphovascular invasion في perforation. في الحالات زي دي then you consider في stage 2 to give adjuvant chemotherapy. What is people talking about microsatellite instability mismatch repair genes? Nowadays this testing is being done to decide whether, especially people in stage 2 tumor, whether they will benefit from the adjuvant treatment or not. Patient with microsatellite instability, which is high, this is genetic testing, or MMR. MMR mean mismatch repair gene, وMSI mean microsatellite instability. إذا كانت المicrosatellite instability is high ولا ال MMR deficient, and colon cancer have better survival rate than those with العكس البروفيشنال العكسهم، يعني كان ال MSI low ولا ال MMR high، فديل عندهم better survival rate than those العكسهم. والبروجنوستيك فاليو more pronounced in stage 2 زي ما قلنا. وعادة إذا كان البيشنت عنده MSI high, usually we don't offer them adjuvant treatment. طيب الريكتال tumor within 15 centimeter above the anal vag as measured قلنا with a rigid rectoscope ولا بالflexible segmentoscope, and you have to take into account the measurement with the flexible segmentoscope. Local recurrence rate and mortality has declined. ليه؟ لأنه there is now better surgery, which is a total mesorectal excision, preoperative neo-adjuvant radiochemotherapy. It play a very good role now in decreasing the mortality and morbidity from colorectal cancer. Any patient now with stage 3 or 4 usually offered preoperative neo-adjuvant chemoradiotherapy, and then we go for surgery after 6 weeks. There is different protocol, like in most of the protocol talks about 6 weeks post radiochemotherapy. This patient go for surgery and the tumor stage is reduced when outcome is better. برضو في outcome is better because of the pre and post-operative care, including improved treatment of post-operative complications. Important finding the treatment you have to consider before doing rectal cancer surgery. A tumor, low rectal tumor is from 0 to 5. Usually you can do anterior resection for a tumor more than 5 centimeter for a low anterior resection. Mid rectum is 5 to 10 زي ما قلنا، above 10 is high rectal tumor. You can decide whether you have to do a high anterior section or low anterior section, depend on the height of tumor. But this is not the whole story, because usually I ask my registrar, the tumor is at 6 centimeters, what are you going to do? It is not just a straightforward question. Tumor at 6, I will do anterior section. You have to consider so many things before you decide if this patient with a tumor at 6 or 7 centimeters will have an anterior resection or not. Depends on first the height of the tumor. Then, is this a male or female? Is it a long or short person? Is he obese or thin? All this, in addition to the height of the tumor, will decide whether you're going for an anterior resection or not. We always tell the patient that your tumor is at this length, and it usually can be done with anterior resection, but sometimes you have to explain to the patient that you might end with abdominal perineal resection. And as I tell you before, it does not depend only on the height of the tumor. It depends on your patient condition, his age, his sphincter status, is he obese or not, a female or male. A male patient usually have a difficult type, and neuropelvis surgery will be more difficult than a female. So to decide whether the patient is going to have an anterior section or an APR is not just the height of the tumor, it depends on other factors. Important finding before the treatment is you have to decide about the tumor height, the TNM stage, a circumferential resection margin. Before we're talking about only the mesorectal, now people are talking about the circumferential resection margin. Is the tumor, the lateral extension of the tumor in the pelvis, the histological type, the patient factor, age, comorbidity, sphincter function, sex. All this factor is very important to decide what type of operation you're going to do. Neo-adjuvant chemoradiotherapy in rectal cancer. Decision for neo-adjuvant radiotherapy is you have to see the clinical oncologist to check the fitness, exclude the contraindication for neo-adjuvant chemoradiotherapy, the active colitis, previous abdominal surgery, previous regional radiotherapy like prostate, anal, or gynecological radiotherapy. Usually, we start chemoradiotherapy for rectal cancer 3 to 4 weeks. Within 3 to 4 weeks from the diagnosis, we start the treatment, and usually it takes 4 to 6 week treatment course عشان ياخذ النيو-adjuvant. And nowadays it is radio chemotherapy, and the chemotherapy is important because it's radiosensitizer, and they give it usually in the first and fifth weeks of this treatment course. You do an MRI or CT 4 to 6 weeks post the completion of a neo-adjuvant treatment, and then you have an MDT discussion. We usually do surgery at 6 to 8 weeks after they finish the neo-adjuvant radiochemotherapy. There is different, as I told you, protocols for giving radiotherapy and when to time the surgery after the radiotherapy. There is a short regimen in which you give radiotherapy and you do surgery within 10 days post radiotherapy, but most of the people use the protocol I tell you before. An operation for rectal cancer, field anterior resection, abdominal perineal resection, extended abdominal perineal resection, and here usually a classical abdominal perineal resection is going straight around the rectum. Field extended, you go and take the lateral muscle of the pelvic floor, and then you have the Hartmann procedure. Preoperative consideration, always antibiotic, preoperative and preoperative thrombosis prophylaxis, bowel cleaning before anterior resection with anastomosis, small enemas sufficient before an APR or Hartmann. Like usually, most of the time we do bowel preparation of our patient before surgery. You have to counsel the patient, you have to mark the stoma site, and always, even if you are planning to do an anterior resection, you have to tell the patient about the possibility of a colostomy, either as a defunctioning or an end colostomy. Local excision, as I told you before, sometimes the rectal tumor present early on, T1, T2, and there is nowadays option for local excision, transanal endoscopic microsurgery available for most of the places now. And early, usually it is done for early tumor T1, and sometimes local excision is done as a palliation surgery for patients with comorbidity in the old age, comorbid condition things like that, sometimes you can consider local excision. And as I told you, endorectal ultrasound is very important when considering this option. A resection, as I said before, fill anterior resection, an APR or Hartmann, proximal ligation of the inferior mesenteric artery, high to low tie, dissection of embryonic planes and polyp planes, nerve sparing. You have to see the nerves, very important to avoid the complication, later complication, sexual and urinary complication. Adhesion or invaded organ, abdominal wall are excised in block with a tumor. A TMA, total mesorectal excision to the pelvic floor, is very important. Partial mesorectal excision دي بنعملها usually we do that في الهاي rectal tumor. You have to go 5 centimeter beyond the tumor, and in that case يعني say the tumor is at 12 centimeter, you go 5 centimeter beyond the tumor, and in that case you wouldn't take the whole mesorectum, but we do partial mesorectal excision 5 centimeter distal to the tumor, والdivision يكون 5 centimeter distal of the tumor border. Usually when you do APRs or anterior resection بتعمل distal wash. I mean في anterior section you do distal wash out before division of the bowel, because the shedding of cells, when you do the stable anastomosis, sometimes you risk implanting and shedding cells دي في anastomotic site. So we usually do distal wash of the bowel. As I say, we have the option of open, laparoscopic, or robotic surgery, and they are all equal for oncological outcome. High anterior resection usually applied for tumor, as I say, above 10 centimeter from the anal valve, division of the mesorectum at least 5 centimeter distal to tumor. Usually when you divide the mesorectal 5 centimeter distal to tumor, avoid coning. يعني ما تمشي to thin الميزوركتم ده وبعدين تعمل له division. You have to divide the mesorectum perpendicular to the rectum, and then you do end-to-end anastomosis, usually double stapling with circular stapler. And usually في high anterior resection, we usually don't do a defunctioning stoma unless you find difficulty in the anastomosis, or you are suspecting problems with the anastomosis. In that case, you have to put a defunctioning stoma. And in all cases now, we do a leak test before finishing the surgery. Low anterior resection, here you have to do a total excision of the mesorectal. A distal margin, as I say, it is 5 centimeter. Like when you're dealing with a very low tumor, 1 centimeter from the tumor border is nowadays considered enough. A temporary stoma for deviation, usually loop alveostomy or colostomy. In other parts of the world, they do the loop alveostomy because of the easy way to close it. In our situation, we find that loop alveostomy have a lot of problems with our patient, especially most of our patients, they don't have a good care at their residence for regular follow-up for the complication of alveostomy. And in our situation, we find that colostomy is better than a loop alveostomy. But in any case, if you go for a low anterior resection, you have to cover that with a loop alveostomy or colostomy. Although in our experience, we do so many cases low anterior resection without a covering alveostomy. We're going to have a paper about this topic. Most of our cases we do an low anterior resection, and we didn't do covering alveostomy. Regarding that we are really confident that our stomosis is good, and we have no difficulty during surgery. We don't put a covering lobar ostomy or colostomy, but for the sake of our registrar, if you ask about if you're doing a low anterior section, then you have to say that you have to cover that with a loop, a ostomy, or a colostomy. Abdominoperineal rectal excision, conventional APR with limited excision of the pelvic floor, levator muscle, or you do extended APR, excision of pelvic floor close to the pelvic side. This is an ordinary. This is the original APR. You go close, you dissect the pelvic floor muscle close to the rectum. This is the extended APR where you go lateral to dissect the pelvic floor. Post-operative, you consider adjuvant chemotherapy to patient with stage 3 disease or stage 2 with high risk. High risk, I talked about it before, is there is involvement in lymph node, poor differentiation, lymphovascular invasion. Then in stage 2, you go also for adjuvant chemotherapy. You should start post-operative or adjuvant treatment for rectal cancer within 8 weeks of the operation. If colon not properly examined preoperatively, then you arrange for post-operative colonoscopy. Usually we do stomach closure 3 to 6 months. Some people they do earlier than that. If no adjuvant treatment, you close them at 3 to 6 months, and then you plan the follow-up of your patient. You follow them with regular colonoscopy, CTs, and CEA levels. Function, anterior resection syndrome, anal incontinence, sexual function, stoma function, all these have to be considered and discussed with the patient and followed after surgery. Thank you very much. I hope you enjoy the talk. And as I told you before, I hope I will, in other lecture, give you the recent guidelines for the colorectal cancer according to the International Society of Cancer. Thank you very much. And if you have
thank you very much, Mr. Omer. Thank you very much, Mr. Omer, for an enlightening and entertaining presentation on colorectal cancer in Sudan. Now it's the time of discussion. We are welcome again Mr. Professor Sulaiman Hussein, Professor Rashid Ahmed Abdullah, Mr. Ahmed Adam, and all of other participants. You are highly welcome. Anyone, please unmute yourself and take the chance.
Hello.
Welcome, Professor Sulaiman.
Thank you. Assalamu alaikum, Omar. Really enjoyed your excellent presentation as usual. And I know it is very, very difficult to cover the topic of colorectal cancer in 1 hour. I think that each part of the talk may take 1 hour. But I think you have been, you went beautifully through all the major, all the common lines of management. But I have got some comments here, just going back to our local setting here.
Okay.
And the very thing I think now, Omar said that there is a tendency to a three-sided colonic tumor. And this will bring us to the anatomical divisions of the colorectum. That now the right-sided colonic tumors are quite distinct tumors from the left side. So the colon now probably most of the time is described as a two-entity organ. A right colon that behave differently, tumor, the molecular pathway, prognosis, differentiation, and even the microsatellite instability pathway, which is predominant to the left side, which is quite distinct. And but I think recently the tendency that it is a three entities. The rectum is quite separate from the colon, and it behaves quite differently anatomically in a closed box. The behavior of the tumor, And not only this, but the molecular pathway now, there is recent data that suggests that it behaves differently from even the left side of the colon. And the response to the treatment, which is quite distinct, that most of the adenocarcinoma of the rectum now, they respond well to radiotherapy, and quite distinct to the left colon. So I think it's better now we take them as three entities: right-sided colonic tumors, left-sided colonic tumors, and the rectal tumors. Coming back to the situation of Sudan, I think our situation is quite distinct from the Western data. In particular, that we are seeing cancer at young age group. And as you rightly said, that in most of the data in Sudan, almost 40% of the patients with rectal cancer, they present below 40 years of age, which is quite distinct from the West. And we have noted that there is a bimodal distribution. There is a group that it behaves similar to the Western data in the left side. They present at 60 and 70, but the majority they present at early onset, what we call an early onset rectal cancer, which present below 40 years of age. And this here comes a question about the carcinogenesis pathway, whether are we the pathway of developing rectal cancer or left-sided colonic cancer, is it an adenoma carcinoma pathway or something like a carcinoma de novo? Because you need 10 years. Now we are seeing very advanced cancer at the age of 20, 25. And adenoma carcinoma sequence, it takes almost 10 years. So most likely this polyp had been there for the last, when the patient was 15 years old. And from our colonoscopy data, we are not seeing much of adenomatous polyps at younger age. So probably the carcinogenesis is quite distinct from the Western data. The other point, most of our patients, they present late. And I think this probably, the tumor is very aggressive, in particular in that, but not, I think this is not the answer by itself, because most of the delayed presentation is not patient related, most likely is a health system related. And patients usually they present with overlap of symptoms, which is quite mimic dysentery, quite mimic hemorrhoids. And the patients are young with rectal bleeding. So the first differential diagnosis comes to the treating health worker is that this is hemorrhoids or this is dysentery. And most of those they are treated with symptomatic treatment. So they keep just moving from one health center to another, changing local treatment to hemorrhoids, to metronidazole, to whatever, till eventually they take them 1 year for somebody to put a finger in to do a digital rectal examination to find an astonishing very low rectal carcinoma. And I think this is probably it is a failure of our health system, that patients are not well investigated. And we keep saying to our students, if the patient, any patient who presents with rectal bleeding, if you cannot do a digital rectal examination, and there is a facility for a rigid sigmoidoscopy, it is better not to see the patient. And I think that sounds good. Most of our 60% of our tumors are within reach of a rigid sigmoidoscope. You don't need a full colonoscopy unless you diagnose the tumor and then you want to exclude synchronous lesion. If you put your finger in, there is a chance to diagnose 50% of our colorectal cancer. If you put a rigid sigmoidoscope, the chance of getting about 60-65% of rectal cancer. If you do a flexi sigmoidoscopy, there is a chance to diagnose almost 70-75% of colorectal cancer. So I think the diagnosis is easy, but I have to address the way we are teaching our students, the practice in our health system. That I think for a long time we are saying that it is very, this basic data that you have to do a digital rectal examination for any patient who presents with rectal bleeding unless it's a painful condition, and here probably you need to do a Neo examination. And then if the digital rectal examination is normal, you shouldn't diagnose hemorrhoid unless you do a rigid sigmoidoscopy to make sure that the first 15 centimeter or the last 15 centimeter of the back of the colon is free. And this is, I think, what I call the minimal package of managing a patient with rectal bleeding. History, examination, digital rectal examination, and rigid sigmoidoscopy. And if the patient presents with fresh blood, most likely the cause is in a young patient, this is hemorrhoids. But if there is any other symptom, that it is a mixed with the motion, if the gentry-like symptom, even if the sigmoidoscopy is normal, then here you have to proceed for a flexi-sigmoidoscopy or colonoscopy. So I think the late presentation, we have to reconsider, I think, the basic rules of management of any patient with rectal bleeding. And I think that it is not expensive, it is very cheap. All you need is a glove finger. All you need probably is a regisigmoidoscope, which unfortunately disappeared from our health centers. But I think in the absence of a regisigmoidoscope, flexi-sigmoidoscopy should be a very reasonable tool to diagnose any patient with rectal bleeding. If you haven't got the facilities to do that, it's better to refer the patient somewhere else. And I think the minimum is a digital rectal examination. If the digital rectal examination is normal, I do repeat, if there is no facility for regisigmoidoscopy, it is better to have a flexi-sigmoidoscopy. The other point which I just want to go over it quickly is that, as you rightly said, Omar, about the rectal cancer in particular, about the neo-adjuvant therapy. And this is why I'm saying that it is quite distinct from the colonic, from the left side or the right side. I think there's a shift in the paradigm now in the management of rectal cancer. And I think the neo-adjuvant therapy has revolutionized the management of rectal cancer. And nowadays, there is a complete pathological response to neo-adjuvant therapy. And this, I think from recent data, this may go up to 25% of the patients, they respond completely to neo-adjuvant therapy. The tumor disappears completely. You take biopsies, normal. You do an MRI, the MRI is quite distinct from the pre-treatment MRI. And I think this is very important in terms of what should we do for those patients. And now we are seeing in our data, it goes up to 15%. What should we do for such patients? Should we just do complete, surveillance of those patients and see what happens, or should we operate? And sometimes if we operate, you may end with finding that this is a completely normal rectum. And so this is, and I'm sure that with the more improvement in our radiotherapy techniques and chemotherapy tool, the story of anal cancer, which now the standard treatment is radio chemotherapy, probably now with an advance in radiotherapy techniques and local radiotherapy, probably the complete pathological response rate may go up to more than that. And here I won't be surprised that in some time that may be the primary treatment for rectal cancer is radio chemotherapy. I think that is the one point also, practical point about the post-operative management. And we found that throughout the patient with anterior resection, they have an esophageal tube. They have a drain being left for 7 days, catheter left for 5 days. And nowadays, it's considered that is the part that delays the recovery of those patients. And I think that we have to adopt now what we call the enhanced recovery program. Those patients, usually, you don't need an esophageal tube unless they develop an alias. Drains, you don't need drain unless it's a deep pelvic dissection in ultra-low resection of the rectum. And you don't need a catheter for more than 24 hours. And early feeding. Those patients, used to start those patients for 5-7 days till they pass wind, till they open their bowel. But for a patient who is stable, with a soft abdomen, you can definitely, with an intact anastomosis, which you tested intraoperatively. This is a patient we can, from the next day, you start 60 mils of water, 90 mils, and then you build it gradually. In the said post-operative day, probably they take free fluids. Catheter out in the next day. Drain shouldn't, if there is a drain, shouldn't be left for more than 48 hours, maximum 72 hours in pelvic drains. So the rapid enhanced recovery, I think that this improved the outcome of rectal cancer surgery. Thank you very much. I really enjoyed your talk, and I think there is a lot of, as you rightly said, you need lectures and lecture to devise this talk in different scope of management. Thank you very much, Omar.
Shukran, ya Suleiman. Very valuable comments. Suleiman talk about get practical. Very important point we talk about, our cancer patient usually occur in young age group, and now the guidelines indicate that any patient who develops colorectal cancer below the age of 50 should have genetic testing. It is important because now, genetic testing will tell you if the patient have a Lynch syndrome and hereditary non-polyposis colorectal cancer. And in those ones, as we talked before, mismatch repair MMR and MSI microsatellite instability. If you test them, will tell you what type of chemotherapy you will use, because sometimes if the people have MMR reduced, they would not respond to 5-fluorouracils and other type of adjuvant, and you have to shift to other protocols. And that is very important, because now we find that also in our local experience that we send people for neo-adjuvant treatment and people came with the same size of the tumor or sometimes increasing size. I think if the facility improve, any patient below age of 50 or 40 should have genetic testing. Hopefully we'll have that in Sudan soon, and that will improve our outcome for the treatment. ERAS, enhanced recovery after surgery, as Suleiman say, we are not tracking that a lot, but we should put it in our protocol and teach our junior staff what ERAS so they can use it in their management for patients. Thank you, Suleiman, for your valuable comments.
Dr. Wala, you are welcome. Please unmute yourself.
Thank you, sir, for the insightful presentation. My question is regarding the inferior mesenteric artery ligation when operating on left-sided tumors. Now, there are some data that shows recently that there's no difference in the 5 years survival between when you do a high ligation or low ligation. So, what's your preferred method?
I agree. I mean, most of the time we do a low ligation, but again, for practical reasons, that depends on the size of the tumor. If you have a big tumor, sometimes you examine the area of the inferior mesenteric artery or the central arteries, and you find lymph node higher up. I think it is wise to go for high ligation and central dissection of the higher lymph nodes. But as you say, most of the recent data showed that for early stage cancers, whether you do a low or high ligation is almost the 5-year survival is the same. But to my opinion, they didn't do it for the higher stages, stage 3 and 4. Which I think will be wiser in stage 3 and 4 to do more central excisions.
Welcome, Mr. Ahmed Muhammad Adam.
السلام عليكم ورحمة الله. مساء الخير كلكم. مستر عمر فاروق يا أخي، شكرا لك على المحاضرة القيمة حقيقي، يعني كانت very elaborating and very nice talk. والكومنتس بتاعت بروف سليمان حسين حقيقة غطت جانب مهم جدا جدا من الحاجة كنت أعلق عليها. أنا حقيقي داير أقول للأخوة الريجسترار، خاصة الناس الدفعة 36 والدفعة 42 وحتى بقية الدفعة، يعني مجلس الجراحة حقيقة منعقد على اجتماعات ودسكشن وكده، وقاعد ينظر لكل العقبات اللي مرت خلال السنه والسنه ونص دي، واخذتها في اعتباره واخذت في اعتباره السوبر تريننج برضه. فان شاء الله الايام الجايه الدفعه 36 الدفعه 42 اللي الفاينل ام دي 36 والميد كورس او الكور اكزام 42 حيسمعوا برضه حاجات كويسه باذن الله. دي اولا. ثانيا انا افتكر انه كلنا بنعرف how to differentiate between the right side, left side and rectal tumor in history wise, behavior wise and outcome wise. لكن actually المشكلة الأساسية اللي بتقابلنا during practice we are not practicing this. We are not taking a proper history. The clinical acumen it lies on a proper history and full ABCs approaching patient with any lower bowel symptoms. That is the important thing to pick up earlier case to treat them earlier for better outcome. This is upper important point we have to consider. حتى في exam, if you couldn't evaluate a proper patient with lower GI symptoms, even if you have a good knowledge, you are not going to pass the case. But this is number one. Number two, كل الجايدلاينز من 2004 بدأت تتكلم انه الافضل سيرجري للريكتال تيومر ما هي الحاجه in the practice. النيو ادجوفنت سكانينج in front. وطبعا في اسباب كثيره تخلي النيو ادجوفنت سكانينج in front for rectal tumor لانها بتساعد في eradication of micrometastasis، وفي سيره بتتكلم انها برضه it reduces the tumor cell shedding during surgery later on. وكلنا عارفين الداون ستيج والبروفينج الريسبتابيلتي later on، وبعد ذلك برضه it improve الاوفر اول سرفايفل. طبعا ده بيبقى فاكت، لكن عشان اطبقه بيعتمد على عوامل كثيره، منها حتى البيشنت كونديشن، منها الستيج اوف ذا تيومر، منها اهم حاجه احنا ما قاعدين ننظر لها هي الكومبلاينس اوف بيشنت. يعني poor compliance patient you cannot go through this very stressful, very lengthy, very costly course of treatment. So this it has to be considered. بعد ذاك حتى institutional environment اللي عايشينها نحن يعني كأطباء في السودان بتختلف من سنترز كثيره. So you have to have a proper and efficient MDT زي ما قال يعني اخونا مستر عمر فاروق. You have to have a proper يعني multidisciplinary team approach so as to adopt these new guidelines. بالنسبه للكولون تيومر actually in advance طبعا it comes in front the surgery، لكن اللوكال advanced tumor is still a neoadjuvant, it has a role. السؤال المهم طرحه بروف سليمان هو انا بعد ما to adopt a neoadjuvant in indicated rectal tumor مثلا anterior rectal tumor, very large rectal tumor او locally advanced rectal tumor، اذا عملت neoadjuvant وبعد ما جيت عملت reassessment after a neoadjuvant ولقيت التيومر is not there, what is the next step? Still there is a debate issue in this. انا اتذكر قبل 5 سنين سالت بروف إدوارد جوناس، هو جانا من ساوث افريكا وعندهم very nice experience، بيقول انه هم they are following the patient، بيعملوا surveillance للبيشنت اللي ما ظهرت لهم تيومر في الكولونوسكوبي او السيجموسكوبي، لو ما ظهر لهم تشو يعني تيومر ولا حتى سين ولا حتى MRI finding، they are following this patient. لكن قال لي هي institutional dependent، we cannot adopt it for a guidelines، it is an institutional dependent. فالحته دي دايره شويه قرايه انه after the new adjuvant rectal tumor what is the next step. النقطه الاخيره الدايره اقولها هي كويشن لاخونا مستر عمر فاروق بين الكولونوسكوبي versus السيجموسكوبي. بدل لمحت انه الناس اللي بيكونوا عندهم clinical evidence of or suspicion of rectal tumor you go for sigmoidoscopy which is a flexible and rigid no longer is available in our center. الاكسبيرينس بالريجيد ذاته ما كويسه، الفلكسبل is very easy and outcome is very good and is available and cheap. Now is it wise to go for a straightforward colonoscopy as an evaluation for lower GI symptoms? I prefer that, or we do for sigmoidoscopy then later on we go for colonoscopy. Again, thank you very much and thank Prof. Suleiman and I advise my colleague الريجسترار انه يا ريت برضه يعملوا لنا كيس برزنتيشن في الكامينج دايز عشان نخش في ديسكشن مع الاكزامينر اساتذتهم وكده يكونوا على الاقل شويه اكزام اورينتد مع النولج بتاعت الاسابيع الفايزه. Thank you very much.
Thank you Ahmed, very valuable comments and questions. طرحت نقطة مهمة the role of neoadjuvant انه التيومر if the tumor is big and you decrease the tumor it is very important الحتة دي الكويشن ده انه now there is a lot of randomized clinical trials showed that if you assess a tumor before a neoadjuvant you have to stick to your initial decision. يعني if a tumor is at 5 centimeter you decide this patient is going for APR and you do you give the patient neoadjuvant a tumor bigger at 8 centimeter then you don't go for anterior resection. You have to stick to your initial decision. لأنه randomized control trials show that sometimes مش sometimes most of the time لقوا إنه في residual tumor cells away from الحتة اللي regress لها التيومر. This is one important point. If you for big tumor, you give neo-adjuvant tumor regress in size, then you go for your initial decision. The number one. Number two, for a complete pathological complete clinical response. طبعا في اثنين complete clinical response اللي هي the clinical tumor disappear، وبعدين في complete clinical pathological response اللي هي التيومر، وبعدين بعد ما تشيل الباثولوجي disappear. برضه في a lot of control randomized trial showed that انه بعد 5 to 7 years 20% even after a complete clinical pathological response, after 5 to 7 years there is a risk of 20 to 30% recurrence. Most of the recent guidelines nowadays برضه دي هتكلم عليها في recent guidelines بتاع 2020. They suggest that even after the complete clinical response you go for surgery. بالنسبة للكولونوسكوبي, as I mentioned before, if the patient is symptomatic and his symptom and he is above 50, you go for full colonoscopy. That's ما فيها اثنين ثلاثة. If the symptom is on right side, you go for colonoscopy. If the patient is below 50 and his symptom is not, يعني combination of symptom is not that aggressive, لأنه الكولونوسكوبي داير preparation وداير waiting list طويلة, we start إذا symptom ما sincere we go for sigmoidoscopy. إذا symptom في left side بس والpatient كان young we go for sigmoidoscopy. إذا طبعا البيست اوبشن انك تعمل له كولونوسكوبي، لكن عشان تديكريز في للريسورسز وكده، اذا المريض young والsymptom is rectum and left side, you start by a sigmoidoscopy, and then if that is abnormal, then you go for a full colonoscopy.
يمكن just one comment Mr. Omer.
Yes, يا سلامة.
يعني أنا if I got it right يا عمر, if there is a down staging, and if somebody present with a 5 centimeter tumor, you found that it and you decided this patient is for APR, you did neo-adjuvant therapy, you found that the tumor regressed and now it is 8 centimeter. This doesn't mean you are going to change your opinion. But I am speaking about those patients. I think, yeah, if you decide this will not upgrade the surgery and downstage the tumor. But for those patients, I think there is enough data now from Latin America. There is recent randomized trial for those who have shown complete clinical response. Hello?
اتفضل يا بروف، يا ريت تعيد النقطة دي لأنها مهمة جدا جدا.
I mean for those who showed complete clinical response, where they showed that the mucosa is intact, you took biopsies normal, you do an MRI, it is negative, and they followed those patients compared. I think there is a very good data recently that showed that even those patients, if they develop recurrence, that you rightly said, yeah, Omar, they may develop recurrence, but the outcome is not worse than if you operated on them early. So at least you defer the patient at least from a major surgery for 5 years. But still there is a hope that a good number of patients, they may do without surgery. So it is a debatable. I think there is still the right answer might not be there.
حتى في الجايدلاينز I agree مع كلامك ده completely. حتى في الجايدلاينز هم خدوا الحته دي بيجلي في الجايدلاينز، قالوا والله البيست ايفيدنت ناو انه في 20% recurrence rate after 5 years. فنحن we advise انه this group of patient put في randomized trials بواحدين في الارم بتاعت الكلوز very close follow up، والثاني الارم بتاع السيرجري على to compare it to. لكن البيست ايفيدنت ريكومنديشن بتاعتهم انه is to go for surgery even if they have a complete clinical.
Another practical point raised by Mr. Ahmed, يا ريت والله we go back نوفر الريجيسيجمويدوسكوبس. It is cheap, available. I don't think that it needs much of experience, and it saves the patient the hassle of sending them somewhere else to do colonoscopy or flexisigmoidoscopy. And now we are using a disposable rigid sigmoidoscopes. This is where you find it in any outpatient clinics. And I think that we have just an enema. Not having a rigid sigmoidoscope If there is the index of suspicion is not very high, and I think it is fast track to give the patient an enema and to do a flexisigmoidoscopy, rather than if there is no high suspicion of a tumor, or if there is not a high suspicion of a proximal tumor. So the advantage of flexisigmoidoscopy, it is fast tracking, doesn't need bowel preparation much. It is a one-stop clinic. If you have got a flexisigmoidoscopy in your hospital, you can see the patient, do a digital rectal examination, give the patient an enema, and you do a flexisigmoidoscopy. Or if the waiting time for endoscopy for flexisigmoidoscopy is very short. If the colonoscopy, you send the patient for a colonoscopy, you may find that the waiting time may go up to 3-4 weeks. But if you send the patient to Soba for a flexisigmoidoscopy, you find that you can do it next week. So you can fast track the diagnosis. So and then if you look at the data, 70% of the patient or 75 are left-sided tumor within reach of a flexisigmoidoscope. So you can have a high chance of diagnosing 75% of colorectal cancer by doing simple rigid flexible sigmoidoscopy, and then later on على راحتك تعمل الكولونوسكوبي to exclude other lesions. But I agree with you, the right side is quite distinct, history-wise, presentation-wise, and this is a type of patient you straight away you go for colonoscopy.
That's right.
Mr. Ahmed Adam, I think you have comment.
انا والله I'm very happy انه اسمع الكلام ده. اول شيء السوسايتي اوف جاستروانترولوجي في السودان اول شيء عندها very يعني good initiative في اي حاجه. حتى في الكوفيد دي اول سوسايتي طلعت very good clear guidelines for their affiliated bodies وكده وممبرز. انا افتكر يا ابو سليمان يعني لو يا ريت برضه لو if you initiate this احنا we are going to help حتى تبقى يعني زي براكتس من داخل المجلس من داخل السوسايتي بتاعت الجراحين السودانيه in collaboration with gastroenterologists in general في السودان. انا خلي this is a very valuable adding point to the practice انه نرجع هذه السيمولوسكوب to our clinic. Thank you very much.
محمد الستودنت الريجسترار كان في عنده question؟
اي واحد عنده اي كويشن ممكن اعمل اميوت ويزعل طوالي.
اعمل اميوت في
ايوه. If no more question, for the sake of time, I think it is very valuable 2 hours discussion in colorectal cancer. Thank you very much, Mr. Omer. Thank you very much, Professor Suleiman. Thank you very much, Mr. Ahmed Adam. Thank all of the participants. We hope to see you in next meeting regarding colorectal surgery in Sudan, and we hope to see you all in good health. Thank you very much.
Okay, thank you. Thank you very much. شكرا يا محمد وشكرا Mr. Suleiman, Mr. Ahmed and participants. Thank you very much. Good night.
Thank you very much. Good night.